السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم جميعا. معكم غيداء فلمبان جي بي. اليوم حنبدأ يومنا الرابع في الإمرجنسي ميديسين سمر كورس، وإن شاء الله تكونوا استفدتوا واستمتعتوا معنا في الأيام اللي فاتت، وإن شاء الله الجاي أفضل. وفي بداية حديثنا وقبل أي شيء نقول اللهم علمنا بما ينفعنا وانفعنا بما علمتنا وزدنا علما. والآن اسمحوا لي أرحب بالدكتور الغني عن التعريف، واللي كثير مننا يعتبره قدوة، واللي دائما نسمع منه First عبدو and the only عبدو. دكتور عبد السيد Emergency Medicine Resident in National Guard Hospital. موضوعنا لليوم حيكون respiratory emergency. محاضرة ممتعة لكم جميعا. دكتور عبدو تفضل.
مساء الخير على الجميع. أولاً شكراً لجميع المنظمين. أنا واحد منهم، بس إنه في خلف الكواليس أعمال كبيرة جداً في الباك ستيج، شيء كثير تم واجتماعات وأشياء كثيرة. شكراً لكل السبيكرز اللي كانوا قبلي، دكتور محمد قضماني، دكتور أنس حمام، دكتور عبد الرحمن الشريف، والبقية اللي جايين إن شاء الله. أتمنى هدفنا هو واحد، إنه الجميع يستفيد، كل الميديكال ستودنتس، الانترنز ستودنتس، الاي ام اس ستودنتس والاي ام اس والانترنز، ميديكال انترنز والنيرسينج انترنز، كلهم they get a maximum benefit from our course. شكرا لكل شخص حضر معنا، شكرا لكل شخص أعطانا ثقته وأعطانا جزء من وقته. إن شاء الله يكون الكورس ثري إن شاء الله وغني بالمعلومات، إن شاء الله تستفيدوا وتطلعوا بأكبر كمية من المعرفة. Today we're going to talk about respiratory emergency. I'm going to talk in a brief, in a simple way and superficial. We will not go in a deep information. راح أشرح بكل شكل مبسط جدا، either إنه second year ولا third year medical students ولا whatever. إن شاء الله الكل راح يستفيد بإذن الله. قبل كل شيء، my name is Abdul Said. I'm an emergency medicine resident at National Guard Hospital. I'm in BY3. I'm always here because I love to educate, to inspire, and to make a positive change. Always, this is my aim. This is our objective today. First of all, we will talk about how can you interpret a chest X-ray? How can you read it in 2 minutes or 3 minutes? How can you read it as an emergency physician approach? Then we will talk about how can you approach a patient with a short breath in our area, in emergency department, asthma exacerbations, COPD, respiratory failure, including ARDS, acute lung injury, BE, pneumonia, pulmonary effusion, pleural effusion, and pneumothorax. طبعا الشات راح يكون مفتوح إن شاء الله. Q&A. If anyone have a question, please do not hesitate to ask us. نوقف break for 5 minutes later، وبعدها راح ناخذ أسئلة، وفي نهاية المحاضرة we will answer all the questions. First of all, there is multiple systematic way you can interpret or read the chest X-ray. بالنسبة لي there is multiple approach. واحد من الأسهل and the easiest approach you can use it to read the chest X-ray is ABCDE approach. There is multiple ABCDE. As an emergency physician, if we will call ourselves by names other than our name, we will say our name is ABCDE. A, it's short for the airway, including the trachea and the right main bronchus and left main bronchus, and bones. B, for bones. Bones, you can use it for ribs, shoulders and spine, and the lower thoracic spine for B. Then C. C is short for the cardiac. You can comment on the cardiac dimension, cardiac size, and whatever on C, costocardiac angles, all of that on C. D for diaphragm and everything below. As we ordered sometimes chest X-ray to rule out air and the diaphragm, we cannot order abdomen X-ray. It will not show air and the diaphragm. We will order chest X-ray. E for everything else, including the lungs. This is for BA view. For lateral view, you can use the same mnemonic. A for airway, including the trachea. You can see the trachea here. You can appreciate the trachea all over on the right and left main bronchus on this bifurcation area. Then B for the sternum and the spine, and C for the cardiac size. You can comment on the cardiac and the area, which is the retrocardiac area, including the lungs here. D for the diaphragm also the same, and E for everything else, including the E, which is the lung. This is one approach. A lot of people, they have using multiple approach. I was using multiple approach, but you can't choose whatever you are familiar with it. Either there is multiple systematic pathway, including the geographic pathway. You can read the X-ray from inner to outer, or from outer to inner, or there is a targeted pathway. As an example, patient, there is a high possibility to he have a pneumonia or he have a lung infection. You're gonna focus on the lung area. ايش العيب اللي بيكون في هذا الابروش؟ انه والجيوغرافيك ابروش from inner to outer, always we are missing something by geographic approach. But دائما لما بعلم resident ولا my colleague ولا interns دائما بقول لهم choose a systematic approach either by ABCDE or another approach, rather than to be a geographic approach from inner to outer, because we are missing something. If I'm going to discover there is an area of infiltration on the right side, I'm going to focus on that. That's what we call it happy eyes. We will attract by one pathology. We will not be attracted to another pathology. Other than this, you can notice the A for the trachea, and you can notice the right paratracheal strip line on the right side. واضح الماوس ولا مو واضح؟ البوينتر. Okay. جميل. You can notice the A for the trachea, the right paratracheal strip line and the left paratracheal strip line. Always we are commenting on the paratracheal strip line on the right and on the left to differentiate the area on the mediastinum and the area around the trachea. This is for A. Also A, including the right hilum, the right hilar area and the left hilar area, and also pulmonary artery. It can be included on this area, but not an A. B, as we mentioned before, B for the ribs, including the shoulders, clavicles, bilaterally, and the ribs and the spine. C for the cardiac size and the cardiac dimension, including on this area, there is a left ventricle. On the right area, there is a right atrium here. Also, the pulmonary arteries, including on the C, and the costocardiac angle. All of this area, you will comment. You can notice the retrocardiac. Sometimes you can notice the retrocardiac infiltration from this area. Uh, Other than C, D, you can notice the diaphragm, and E for the everything else, including the lungs. Including the lungs, from inner to outer, you can scan all the way from inner to outer. The same way work, the same approach work for the left side. Just I have one comment. Always we are saying this patient is centralized well or not centralized well. We are commenting with the spinous process. If the spinous process dissecting the trachea midline, we are saying this is most likely the centralized chest X-ray or BA chest X-ray. This is totally wrong, because always on the, even on the high quality chest X-ray and BA view, we can notice there is some sort of tracheal deviation or tracheal uncentralized trachea. For that, I'm gonna show you just one thing. You're gonna notice the clavicular head on the left and the clavicular head on the right. On the midway between both of them, show for the spinous process. If the spinous process dissecting or on the midway between the two clavicular heads, this patient have most likely a centralized chest X-ray. This is quick approach. We have a lot of area to cover it later. Some fundamentals. Always, I'm teaching my colleague, I'm teaching the interns, sometimes the nurses. They are expert more. Some of them they are more expert than us, but this is a huge and huge crucial area. I'm going to stress on it. If you have a patient that he have a dyspnea or he have a short breath and he's deciding a little bit on 91, 92, what you will choose by this one? Nasal cannula, face mask, Venturi mask, or Fenty mask, or non-breather mask? Absolutely, you will say to me, I will use nasal cannula, because this patient is minimally desaturating. For that, the minimal amount of oxygen, it will be delivered by nasal cannula. From that, you will escalate the oxygen source upon your patient demands or your patient's need. Nasal cannula, most of the patients in the world, they put them, they are not in distress, they put them on the nasal cannula. Most of our patients, we put them on nasal cannula. Nasal cannula, actually it gives us a flow from 1 to 6 liters per minute, which is a good amount. And it will deliver from 22 to 45% of oxygen. Then after it, you will have a face mask, which is giving us flow from 6 to 10 liters per minute. It's after the nasal cannula, and it will deliver about 25 to 60% of oxygen. Then we have some of the hospitals, they are not having a Venturi mask or Fenty mask, but some of the hospitals, they have it, which is a good oxygen source. It will deliver from 3 to 15 liters per minute. And it will deliver an oxygen from 24% up to 50%. This is on the percentage, 24% up to 50% by Fenty mask. Non-rebreather mask also, it will give us flow from 10 to 15 liters per minute. And it will deliver 80% up to 95% from oxygen. After that, you can escalate your patient upon his demand to non-invasive mechanical ventilation like CPAP, BiPAP, high flow nasal cannula. Then if the patient is requiring an invasive ventilation, then ATT or other sources it will deliver. Please capture this slide. It's so crucial for the nurses and EMS and medical students and even the resident. Dyspnea. Always this term يعني انا احس انه اكثر تيرم مظلوم يعني في الميديكال فيلد. كتمه، الم صدري، it may be referred to a different terms. And just in a brief definition, it's dyspnea is defined as an uncomfortable sensation of breathlessness, which is an air hunger, and it is non-specific spectrum from mild disease to severe disease. It can include whatever you want on the chest or the trunk. But كل البيشنت اللي ضيقة، كتمة، ألم في صدري، everything it can refer to dyspnea. This is another terminology I want everyone to save it in their minds. Tachypnea, including the RR, is more than normal. In the adult, from more than 18, on the neonate, more from 45 to up to 60 breaths per minute. Hyperpnea is a little bit different from tachypnea and a little bit different from hyperventilation. Hyperpnea is greater than normal minute ventilation to meet the metabolic requirements. In another way, hyperventilation, when your minute ventilation exceeding the metabolic demands. DOE, which is this dyspnea on exertion, it's defined as a dyspnea that provoked by any physical efforts or any exertion. Orthopnea, as we know, dyspnea on recumbent position, and BND or paroxysmal nocturnal dyspnea is sudden short of breath at the night time. Let's start by one case. This patient presented with a short of breath, and he have a vital sign of heart rate of 120, blood pressure 140 over 90, and he's obviously tachypnic, having an RR respiratory rate of 36, and he's and obviously desatting, having an oxygen saturation of 84. What you will do with such a patient? Please tell me. Absolutely ريان. You are totally right. بس باقي شوية ناقص. يا سلام. ABCDE. Always. ABCDE is a good approach and your safe approach. A for the airway, if the airway is patent, and B for adequacy of breathing, and C if the oxygen is sufficient or not. And you can refer it to the cardiac issue, the patient having a good cardiac status or having good perfusion status in terms of blood pressure, heart rate. Airway, we'll make sure that the patient have a patent airway. You'll notice that if the patient is able to speak, if the patient is able to respond, that means there is no obvious upper airway obstruction. And if the patient have some sort of stridor, that means there is some element of upper airway obstruction. Then you will notice that if the patient have a low glass coma scale, their airway, upper airway soft tissue, it will be affected in terms of the tones. It will be minimized. For that, the possibility of airway obstruction, there is. Look for the cause. If the patient is having upper GI bleed or he's actively vomiting and he's not protecting his airway, you're going to do suction, swelling in the trauma and allergic reaction, you're going to use the medication. If the patient have a low glass coma scale, it's not always means that he is for intubation. Some of them, they are not, they are protecting their airway, but they are at the same time, they have low GCS. But keep in mind, low GCS sometimes means you should prepare for intubation. B, which is breathing. You can ensure that oxygenation is in a good way and ventilation in a good way. Look for the patient's general look. If he's in respiratory distress or using accessory muscle, if on auscultation, if he have an absence of breath sound, which is we refer it as silent chest, you will act immediately. Do not jump from A until you solve it. Do not jump from B to C until you solve it. This is rule number 2 after the ABCDE, which is the rule number 1. Do not jump from A to B until you solve A. Management on breathing, you can escalate from nasal cannula, as we mentioned before, up to non-air breather, up to the CPAP and BiPAP non-invasive ventilation, and then mechanical ventilation, including the invasive ventilation. Circulation, you're going to make sure that the patient have a good blood pressure, is not that much tachycardic, and he's not having just respiratory problems. Quick investigation, we can utilize it. You can utilize it in our area, like point of care bedside ultrasound. You're gonna have a look on the cardiac status. Maybe this patient have a short breath due to a cardiac issue rather than to be respiratory issue. You will use an ECG, which is the cheapest paper in the world and the most effective paper in the world. It will give you a big hint about the cardiac status. It will give you the cardiac problems rather than to be respiratory problems, even on the B. We will mention that later. Chest X-ray, including portable or departmental chest X-ray, it will give you a big hint about the source of dyspnea. This is a broad differential diagnosis for this dyspnea. قلت لكم في البداية إنه أكثر مصطلح مظلوم في الميديكال فيلد, which is ranging from the differential diagnosis from cardiac to pulmonology to abdominal cause to metabolic, even traumatic and hematologic and neurologic. Cardiac, the most important and the most fatal is acute coronary syndrome and arrhythmias and cardiac tamponade. Also peripheral heart disease and acute decompensated heart failure. In the same way, for the upper airway obstruction, if there is any foreign body, if there is any element of anaphylaxis or angioedema, on the parenchyma, if there is a possibility of BE, and on the pleura, check for the evidence of pneumothorax. Abdominal, if they have, if they are pregnant, and if they have an ascites, if they are morbidly obese, the intra-abdominal pressure, it will minimize the diaphragm activity. Metabolic, the same. For decay and thyroid, do not miss it. This is another rule. In the absent, if the patient presents with dyspnea and there is no any element of respiratory problems, think about metabolic and toxins. Traumatic, including the neck trauma, pneumothorax, BE, pulmonary contusion, flail chest, rib fracture, and diaphragmatic rupture, and also tamponade. Acute chest syndrome and anemia and hematologic disease, and neurologic for stroke and Guillain-Barré and multiple sclerosis. On physical exam, as we mentioned before, notice if there is any element of upper airway obstruction, and on the lungs, you will notice if there is any crackles, if there is any element of bronchial breathing sounds. If the breath sound that absent or decreased or minimized on the one lung, please keep in mind the pneumothorax. Asthma or COPD, both of them, they are presenting noise and crackles and decreased breath sound on some of them. Heart, you'll notice for if there is any productive cough of sputum, if there's any crackles, this is it's more toward the pulmonary edema. Pericardial effusion, if there is a muffled heart sound or distant heart sound. Tamponade, if you have the big triad, one of them is hypotension. And GVD. Acidosis also, as we mentioned, before. Tachypnea without the symptoms of respiratory distress and normal oxygen saturation, please think about metabolic acidosis or endocrine issue. Let's start by one case. This is 28 years old woman with a history of lung disease present to the emergency department with difficulty of breathing. On auscultation, you note that there is a diffuse wheezy chest bilateral, and her vital sign is 109 for the heart rate. She's tachypneic, 28, blood pressure on the a little bit lower side, 102 over 75, and oxygen saturation, she's obviously desating room air. What does this patient have, and how can you approach such a patient? Absolutely asthma. I like it. Excellent. Absolutely, this patient have an asthma exacerbation. The most common misdiagnosed and mislabeled for a lot of patients. They mislabeled as an asthma patient, and they are not. Also, a lot of asthmatic patients, we mistreat them and we misdiagnose them. The definition of asthma, just I want you to save in your minds that three words: a chronic, reversible airway inflammatory disorder. Chronic and reversible and inflammatory. After that, even you will know the pathophysiology. You will know how can you deal with such disease. All of the recurrent episodes, it's not an acute from the definition, it's a chronic of wheezing and breathlessness and chest tightness and cough. It's variable degree. And which is good on asthma, it's totally reversible sometimes on the mild and moderate cases, totally reversible. And I mean by reversible, you can reverse the broncho constriction to dilate the bronchus, not to reverse the diagnosis or to solve it completely. This pathophysiology, it's ranged from bronchial constriction up to the airway remodeling, which is the advanced phase of the asthma. We will start by, and even the reversibility, it will be minimized by advancing of the bronchial constriction to bronchial edema to mucus plug, and the goblet cell, it will be increased, and the bronchial muscle, it will be hypertrophied. And the last stage is airway remodeling, which is a totally advanced stage. Triggers, the most common triggers is upper respiratory tract, allergy, a lot of triggers as you know it, smoke, chemicals, a lot of triggers. I want to stress on one thing, which is the beta blocker. Beta blocker, it will affect the asthma and to exacerbate the asthma, even the eye drops. Asthma symptoms, all of us, we know the asthma symptoms, as we mentioned before. But I want to stress on one thing, which is the most commonly missed and not well understood. Not every wheeze means that the patient have a bronchial asthma. There is wide differential diagnosis of wheeze, not only bronchial asthma. From the cardiac problems, including the valvular heart disease and congestive heart failure, COPD also, they can present with the wheeze. Pneumonia also, and upper airway obstruction, they can present if the patient have focal cord dysfunction or foreign body, they can present with a wheeze, and also BE, and also anaphylactic reaction and allergic reaction. A lot of differential diagnosis. Please keep in mind that not every wheeze means that the patient have a bronchial asthma. Diagnosis, a lot of way to diagnose bronchial asthma in our area. One of them is bedside spirometry. Some of the emergency department, they have it and they are utilizing it. And also the pulse oximeter on your clinical judgment. Clinical exam is superior to everything. BFT on the OPD setting and outpatient setting. Chest X-ray is not indicated for any bronchial asthma exacerbation. Please. There is just a minimal situation that the chest X-ray is required in bronchial asthma patient. If you have a suspicion of some sort of complication, like a pneumothorax, or there's some element of infectious process, if the patient is still requiring multiple sessions of nebulizer, the patient requires admission. This is the only few situations that you need a chest X-ray for bronchial asthma exacerbation. ABG also, it's not indicated at all. You can use FBG instead of ABG, and there's some circumstances you can utilize it. This severity of asthma, you can use this table from mild to moderate to severe. You will range the respiratory rate from mild, a little bit, it's gonna increase. On the moderate, the same. On the severe form, some of them, they have respiratory depression. They are not tachypneic. They are not having a respiratory effort. Breath sound from wheeze to unequal to decrease or absent. Using accessory muscle on the mild, the patient, he will not use the accessory muscle. Moderate, the same, and severe. This is so crucial slides. I brought it just for one reason. If you will not ask any asthmatic patient any question, and you know he's asthmatic, just ask him these questions. Because these factors, it will give you a big indication that the patient, he's having a significant risk factor for death, including the previous severe exacerbation that require ICU admission or intubation. If the patient have a 2 or more hospitalization, he was admitted for 2 or more times within the past year, on the same work for ED visits, 3 or more ED visits for the last year, hospitalization the same on the past month. A lot of risk factor, please ask for it, including the social history. If the patient have some sort of psychosocial problems, if he have low socioeconomic, or he's living and he's having a difficulty to access the your ED, this is so risky patient. What I mean by this risk factor, if the patient gets sick in one time in their life, they will be sick in the future. باختصار، من كان له ماضي سوف يعود إليه. If they get sick in the past, they will get sick in the future. For that, please ask for this question for any bronchial asthma patient. Asthma medication, I'm gonna summarize it on one slide, and one mnemonic, BIOMES, which is for the beta agonist, the beta 2 agonist, including the salbutamol, we know it, and keep in mind the bronchodilator or short acting beta agonist, it's a beta 2 agonist and have unwanted effect on the beta 1. For that, most of the patient, they will have some sort of tachyarrhythmias when they received the salbutamol or beta agonist. Ipratropium, just keep in mind, the ipratropium is not generally indicated for any patient, especially the mild cases. From moderate to severe, for that, you will give ipratropium. Oxygen, the same work. Magnesium sulfate for the severe cases. and the patient they present on severe respiratory distress that require magnesium sulfate or epinephrine, this is a big indication for admission. You cannot discharge them most of the time. And steroids, which is work as an immunomodulatory agent, and to prevent the relapse, and you will address the inflammatory process just by steroids. Another case, 2-month-old, previously healthy infant brought by family to your ED with the history of nasal congestion, reported by parents that the baby have low-grade fever noted at home. Vital sign, tachycardic 175, RR 65, oxygen saturation is 92, and temperature have low-grade temperature of 37.8. And your infant is in moderate respiratory distress, and he have a wheezy chest bilaterally. How can you treat this patient, and what does this patient have? I like it. Oh yeah, racemic epi or IV, pneumonia, RSV. I will talk about RSV. Absolutely, you are right. This is a bronchiolitis. I put it just on one slide. I'm a big believer that we knew the COVID that just came throughout the last few months, 6 months, but we are dealing with the bronchiolitis since years back. For me, bronchiolitis is more complicated than COVID because we know COVID and we know that there is multiple medication that can work with COVID, but bronchiolitis, and up to now, there is nothing work. There is nothing work. You will treat them, you will treat their symptoms. And also the RSV, bronchiolitis, it's a clinical diagnosis. There is no need for X-ray, some of them, and there is no need for RSV for all of them. RSV just created for just epidemiological reason. For that, I will not put this patient, the bronchiolitis patient, on the bed near from the oncology patient or the immunocompromised patient. That's it. Bronchiolitis is a clinical diagnosis. Acute bronchitis, just one word, I want everyone to memorize it. Acute bronchitis is chronic cough, a little bit chronic cough, productive cough that lasts for 5 days or more, and it's not require any antibiotics. All the evidence, they said you will treat their symptoms, but there is no need for antibiotics in acute bronchitis. Another scenario, 64 years old man present to the ED with the dyspnea for the last 2 days. He have an extensive history of extensive smoking throughout the past year. He is in moderate respiratory distress with a crepitation that bilaterally all the lung field. What does this patient have? Absolute COPD. How can you treat this patient? We will talk about that just in a few minutes. This patient absolutely have a COPD. COPD in the same way. I want you to memorize 3 words, only 3 words. That the definition of COPD is a chronic, inflammatory, and progressive, which is a little bit more progressive than the bronchial asthma, and is not a fully reversible. Just 3 words. The pathophysiology is a little bit different from asthma pathophysiology in terms of inflammatory markers that have a neutrophilic effect, not a xenophilic like in asthma. This a table from our reference Rosen, including the causes of acute decomposition of COPD patient, including infectious process. Other the infectious process, there is multiple critical events that mimic the acute exacerbation of COPD, or that make the COPD exacerbated more and more, including viral, bacterial, atypical bacterial process, also pneumothorax, BE, decompensated heart failure, pneumonia, a lot of differential diagnoses. Keep it in your mind, please. Management of acute COPD exacerbation, it's worked for the same for asthma, but there is a minor change, including the beta agonist and ipratropium the same, and prednisolone. Always we are giving prednisolone to prevent the relapse, but it will not work immediately. It will prevent the relapse. It will not work for the inflammatory process immediately in our area. Non-invasive positive pressure ventilation, BiPAP or CPAP, it's a magic for COPD exacerbation, especially in the severe form of COPD exacerbation. Antibiotics is not always recommended, especially if you have a suspicious of infectious process, or the patient still have a moderate to severe form of exacerbation, and he is reporting that the cough amount and the cough, the sputum amount and the cough frequency that gets worse recently. For that, you'll give him antibiotics. ARDS, I will talk about it in a brief way. ARDS, or ALI, acute lung injury, or acute respiratory distress syndrome, is a clinical diagnosis. There is multiple way to diagnose ARDS. This is beyond our scope today. I'm going to talk in a brief and so simple way. I will mention one thing. You can differentiate between acute respiratory distress syndrome in a quick way, or you can make a hint about it, and to differentiate between ARDS and SCAPE, or symptomatic cardiogenic acute pulmonary edema, or non-cardiogenic pulmonary edema, by the ventricular status or ventricular function, and the hypoxia and diffuse alveolar filtration. Most of these, it will come with the ARDS, but you can differentiate if the patient have cardiac disease in their background. You will notice that most likely not an ARDS, and most of our patients they are not presenting an ARDS picture in our area. They are presenting in another way in terms of pneumonia, infectious process, or COPD exacerbation. Then they will be complicated on the ICU setting or on the wards. Causes of ARDS, a lot of pulmonary and non-pulmonary causes. The pulmonary, including the pneumonia, aspiration, inhalation, injury, pulmonary contusion. Also, non-pulmonary, including the pancreatitis, trauma, TRALI or transfusion reaction, acute lung injury, non-cardiogenic shock. Treatment, evidence-based. Nothing works for ARDS. Most of the ARDS patient, unless there is a few points, you will support them in terms of saturation, oxygenation, while minimizing the FiO2 and airway pressure. A lot of protective measures, including minimizing the FiO2 or tidal volume. This is beyond our scope today. Evidence, as we mentioned, low tidal volume, lower mortality. This is the only evidence for the ARDS, and the prone position also, that improve the oxygenation, and this is what came recently with the COVID. Just 2 minutes اشرب فيها مويه ونتكلم فيها. في المحاضرات اللي قدمتها أكثر من مرة السنة هذه دائما بقول إنه you were born an original way, do not die as a copy. دائما أقول إنه أطلق العنان لمخيلتك لإبداعاتك. في أشياء كثير وقفت عند حاجز الخوف بالنسبة لنا، ووقفنا إحنا عند حواجز الخوف ما تجاوزناها أبدا، وما حطينا في بالنا إنه في إنه إحنا 7 مليار على وجه الكرة الأرضية خلقنا لنعيش نفس الحياة. أبدا ما خلقنا لنعيش نفس الحياة. وما الإبداع أبدا ما كان مقتصر على 1% from the people around the world. الإبداع ما كان مقتصر أبدا على فئة معينة من البشرية. ودائما أقول أنت مختلف، رسالتك مختلفة، حضورك في هذا الكون مختلف. أبحث دائما عن تفردك، لا يوجد لك نسخة تقارن نفسك بها إلا إذا أردت أن تكون أنت النسخة. فدائما أبحث عن تفردك في كل مكان. أنت نسخة فريدة، لازم تؤمن بهذا الشيء. Then we're going to resume our theoretical part by a BE. It's a big topic, a little bit, but we're going to divide it. We're going to smash it in a good way. Brief, BE's definition is a clot that formatted in another area in the body that transferred to the pulmonary arterial trees, either on the main or segmental or subsegmental arteries. And the pathophysiology, all of us, we know that the pathophysiology of BE, that there is a clot that developed on the deep veins of the leg that break and travel to the via venous system to the right side of the heart, then it will shower to the lung. This is a brief about the pathophysiology of BE. BE signs and symptoms, a lot of things you can include. You can include it in a BE. But I brought this table, which is a good table, that show the percentage of the symptoms and the sign for BE that's range from the dyspnea at rest or with exertion. 73% of the BE patients that have it. Pleural chest pain and cough, orthopnea, calf or thigh pain or swelling, then wheeze, which is I mentioned before. Some of BE patients they present with a wheeze, hemoptysis also, and the sign also tachypnea. If the patient is tachypnic, 54% that the patient have or BE patient 54% of them they have tachypnea. Tachycardia, rails, decreased breath sound, GFD, a lot of signs. ECG findings, this is the most interesting part for the resident to say this or to enumerate the ECG findings. But I want to stress on one point, that we are doing ECG in suspected BE patient, not to rule in BE, but to rule out the other differential diagnosis, which is the cardiac diagnosis, other than to rule in the BE. There's no rule of ECG to diagnose a BE at all. We are diagnosing another pathology or the cardiac cause. But keep in mind, ECG, there is the BE patient, they will not show an ECG finding until they have either an element of acute or subacute pulmonary hypertension. For that, they will present with the sinus tachy, non-specific state change, TUF change, the S1 Q3 T3, all of us we know it, complete or incomplete heart block, a lot of right axis deviation, ST elevation on the V1, a lot of differential, ranging from the more common and the less common. Just I want to stress on one point. Most of the BE patient, they present with the normal ECG. X-ray, a rare finding, but I want to stress on it. Like a Western mark sign, which is the just sudden cut off or sharp cut off of the chest radiograph or pulmonary vascularity, you can see on the left side of the screen. Hampton Hum اسميها دائما الجبنه المقلوبه. I saw it just once. Have a good specificity for BE, which is 82. On the same, Western markets have a better specificity in terms of 92%. But keep in mind, as I mentioned before, majority of BE patients, they present to a normal ECG. Majority of BE patients present to the normal chest X-ray. Confirmatory test that we can use it for a BE patient, like a FQ scan or CTBA, CT scan, CT pulmonary angio. We can use it. A lot of studies done for this and this. Most of the our utilization for the FQ scan for the pregnant lady, and also for the patient, they have a big element of allergy to the contrast, or we are trying to avoid the contrast on the CTBA. Circle of death. دائما نحن في بالنا بيجي انه الBE patient, they will die from the respiratory cause rather than to be cardiac cause. To be honest, and the right thing is, BE patient, they will die from the cardiac cause, not the respiratory cause. And this is what I call it the circle of death. If you have a BE, patient having a BE, the pulmonary vascular resistance, it will increase. The RV, right ventricular pressure overload, it will increase. Then the RV, right ventricle, it will function, it will be minimized. Then the septal part, it's gonna shift, or it's gonna increase toward the LV part. I mean by that, the diameter of RV, it will enlarge more and more. It will get bigger than the LV diameter. Then the LV cardiac output or preload, it will be minimized. Then the LV cardiac output, it will be minimized. The same way, on the same, after that, the systematic, the blood pressure, it will be minimized. It will decrease. The coronary perfusion, it's gonna decrease more and more, and the circle will continue to the increase of the volt of the RV ischemic process and infarction, and the same way بنرجع مرة ثانية. Just to summarize, there's some element of increase in the pulmonary vascular resistance. The RV diameter will increase or enlarge more than the LV dimension. For that, the LV preload, and it will be minimized or decreased. Then the cardiac output is gonna minimize. This is the circle of death in BE. Types of BE and their management. These are 4 types of BE: low risk BE or small BE, non-massive BE, submassive and massive. Just I want you to know from this slide is that massive and submassive BE, massive BE, they can present in a cardiac arrest status, and they will have a systolic blood pressure below 90, and they will show respiratory distress syndrome. And on those patients, TBA is a must. On submassive BE, they will present with moderate distress and they will be desatting, and you're going to consider on that patient also thrombolytic. Low risk and non-massive BE, you cannot give them thrombolytics. You're going to start heparin. You can discharge the low risk at home, to home. You can admit the medium risk to high dependent area in your hospital, and you're going to start the treatment immediately. This is another scenario that is a 70 years old male patient with a prior medical history of diabetes, hypertension, ischemic heart disease, brought by a family with a history of fever, productive cough, short breath that started yesterday. Vital sign, including the respiratory rate, is he's tachypneic, he's tachycardic, and he's febrile, and he's a little bit destatic. How can you approach such a patient? Perfect. Perfect. Absolutely, this patient having a pneumonia. Pneumonia, we know all of us that the pneumonia is chest infection, but I want you to know that the pneumonia it will not develop until the host defense are overwhelmed, and the organism is gonna show up more and more. And if you aspirate a large amount of oropharyngeal organism, not a small amount of oropharyngeal organism, we're going to divide it: typical, atypical, viral, like influenza, viral influenza, also COVID, atypical Legionella, mycoplasma, chlamydia. Typical, the most common is Streptococcus pneumoniae, Haemophilus influenza, and staph aureus. This is a schedule you can classify. يعني تعلمنا احنا في الميديكال سكول هذا السكيدول كان موجود انه how can we differentiate between Streptococcus pneumoniae, Haemophilus influenza, and staph aureus, and we will classify the pneumonia upon the organism that causes pneumonia, and they are typical presentation and typical host. I will not talk about that in the details. Just I want you to know that Rostis, Butam, and single Rigers is not that much specific for Streptococcus pneumoniae. Atypical pneumonia, as I mentioned before, the same clinical feature and special feature, but I want you to know that atypical pneumonia, they will present with extra pulmonary finding. They will not present like atypical pneumonia with just pulmonary findings. Then, clinical presentation of pneumonia patient range from by percentage, cough, the most common clinical presentation for pneumonia, fatigue and fever, dyspnea, sputum production, melodic chest pain. Investigation, the same. CBC, you're going to look if there is any element of leukocytosis or infectious process. Chemistry, the same. We will order electrolytes for atypical pneumonia. They have some sort of hyponatremia, and PBG is going to give you a big hint. I like the PBG actually. PBG ورقة صغيرة جدا. Within 2 minutes والPBG عندك نفس الكلام الاي سي جي كلهم ما يكلفوا على بعض ريالين. We're going to save life by them. الPBG والاي سي جي. Chest X-ray, it will give you a big hint about pulmonary status or pulmonary picture. CT, if you didn't, you didn't have a clear picture on the chest X-ray. Aspiration pneumonia, I want you to know that Not all of the aspiration pneumonia have should have a typical picture of the same picture for pneumonia. I want you to know also the risk factor for aspiration pneumonia, which is the seizure patient, the stroke patient. We saw multiple patients that present with stroke or acute stroke or subacute stroke that they have aspiration pneumonia. والمرة الثانية إنه بقول do not be attracted to one pathology. The smart physician, he will not be attracted with one pathology. The smart physician, he will not rely on one pathology, and he gonna discover one pathology, and he is keeping to look for another pathology. Keep looking for another pathology, please. Risk factor for us for aspiration, I mentioned before: altermental status, dysphagia, neurological process, by iatrogenic, either by nasogastric tube, endotracheal tube, trach, bronchoscopy, all of them. Most of them didn't need antibiotics. Not most, يعني up to a good percentage. Most of them need a supportive care, and to repeat and to do a serial X-ray. هذا الكويشن اللي دائما بنسأل فيه إنه we should admit every pneumonia patient, or we can discharge all of them, or how can we risk stratify our patient that present with a pneumonia picture? There is just multiple scores, including the BSI, Pneumonia Severity Index, and CARB 65. You can use whatever you want, but CARB 65 is a good tool. You can stratify your patient upon it. C for confusion, catch 1 point. If your patient having confusion, he gonna catch 1 point. U for uremia, R for respiratory rate more than or equal 30, blood pressure, B for blood pressure. 65, the age. Your patients have age more than or equal 65. Most of them, they are requiring admission. And this is the score, risk groups, and they risk stratify them upon the next 30-day mortality. And you can discharge the low risk, and absolutely you can admit the high risk by CARB 65. Use it. You can use it in MedCalc apps. Summary of pneumonia treatment. This is small summary. You can use it. Outpatient, young, healthy patient. Most of them they have strep pneumonia, and some of them they have atypical pneumonia. You're gonna use macrolides. It's gonna work for them. Inpatient, older or sicker. Healthcare strep pneumonia. The last classification, they use FAB and community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia or acquired pneumonia. And this is the antibiotics for every types of patient, pneumonia patient. This is a question. Give me your finding on this X-ray, and please plot it on the chat. I like it, ريان. أنا كنت منتظرك من أول ريان. The most active guy. I like it. Meniscus. I like it. This is what we mentioned. This is the meniscus sign. This is most of the pleural effusion patients, they present with this, not most of them, some of them, they present with this sign. We call it a meniscus sign. Pleural effusion, we can classify the pleural effusion patient to two types, either transudate or exudate. Transudate, that caused by imbalance or increase in the hydrostatic or oncotic pressure. And the most common had a question on the SMLE question and medical school question, and also board question, lights criteria. The most common cause for transudate pleural effusion is congestive heart failure and cirrhosis. And also in the same way, exudate or exudative. The most common is the pneumonia and malignancy and MBE. And we can stratify them, we can classify them by using the protein of the pleural fluid and the protein of the serum, and LDH of the serum, and also the pleural fluid, and also the LDH of the pleural effusion. If the LDH of the pleural effusion more than 2/3 of upper limits of the normal, this is most likely to have a parapneumonic or exudate. This is some interpretation for cytology of the pleural effusion on the lower side here. And this is a board question, an SMLE question, or also medical school question, lights criteria. The sensitivity of, it's have a good sensitivity for exudates and both transudates. Another question, put your answer on the chat. A 28 years old female patient presented with a history of pleurotic chest pain and shortness of breath that starts suddenly today. What you can notice on the chest X-ray. يلا ريان. وعد. Excellent وعد. Right side pneumothorax. You can notice here what we call it sometimes deep sulcus sign. And we will talk about pneumothorax in a brief. Causes of pneumothorax. Also, the classification of pneumothorax, it depends on the causes. We have spontaneous pneumothorax and traumatic pneumothorax. The traumatic pneumothorax, we will talk about it later on the trauma day. But today we will talk about the spontaneous and also the traumatic in a brief way. Spontaneous that have primary or secondary. Primary, when the patient have nothing, there's no underlying lung disease. Most of these patients, those patients, that they are smoker or they have some sort of genetic factors. And most of them, they are tall, thin. This is for primary. Secondary, there is an underlying lung disease like COPD, asthma, or TB, or BCB, pneumocystis jirovecii pneumonia. Most of them in the secondary. This is for the causes. Trauma, also either puncture of the pleura that lead to air into the space, or iatrogenic that we cause it. We didn't mean it actually. Some of the patients, they present with either hemothorax, pleural effusion. We insert the ICT, intercostal chest tube. Then they developed a pneumothorax, and also the intercostal nerve block. Some of them, they get complicated by traumatic pneumothorax. Trauma also and penetrating injury, either by open wound to the pleura or rib fracture. Presentation, as we mentioned before, chest pain on the affected side, either right or left, severe, sudden onset, stabbing, sharp. Some of the pain radiating to the shoulder and pleuritic. they will have dyspnea. They will be a little bit tachypneic, desating. The breath sound on the affected side will be minimized or it's going to be absent. Also, you're going to notice if there is any trauma history or recent procedure. And you're going to expose the lung, expose the chest, and you will look for any evidence of wound, fracture, flat chest, and all of the picture above. Tension, they will present with the respiratory distress, contralateral tracheal deviation, and increase of the GFB, jugular venous pressure, and they will have a low blood pressure, and the breath sound it will be affected or absent on the affected side. Investigation. It's ranged from point of care bedside ultrasound to chest X-ray to CT chest. But I want you to know one thing, and one rule of one on tension pneumo. Tension pneumo is a clinical diagnosis. If you did a chest X-ray and you noticed that your patient is having a tension pneumo, this is a big alarm for your exam, physical exam. Tension pneumo is a clinical diagnosis. For that I get يعني بستغرب انه بشوف X-ray, multiple X-ray for tension pneumo. Tension pneumo is the clinical diagnosis. On the middle, we have what we call it is a point of care bedside ultrasound lung study. It shows that the barcode sign, we know that seashore sign is a good sign. That means that there is a good pleural movement and there is a good inspiration and expiration process. But when we have a barcode sign, it's like a barcode on the M mode on the ultrasound. This is most likely pneumothorax. There is multiple algorithm for diagnosing a pneumothorax, lung point, lung pulse. A lot of this is beyond our scope today. Also, chest X-ray, you can notice the lucency on the affected side. And you can notice on the chest X-ray, the lung is totally collapsed on the left side. And also, keep in mind that the small pneumothorax, it will not appear on the chest X-ray, and you can notice here on the CT scan that there is an obvious element of anterior pneumothorax, and we always pushing the patient on chest X-ray, nothing, chest exam, nothing, point of care ultrasound, nothing. We push the patient to CT chest. They bounce back to have, or they result back with an evidence of pneumothorax. Small pneumothorax, not a large pneumothorax. We cannot send the patient with a large pneumothorax. We didn't discover it most of the time. How can pneumothorax kill? We know that the oxygenation and ventilation will be minimized. We know, but if there is an open pneumothorax, the air, it will leak more and more towards the pleural space, and then the mediastinum, it will be it's gonna shift it to the contralateral side, toward the opposite side. Then the venous return to the heart, the intrathoracic pressure, it will increase. The venous return to the heart, it will be minimized or decreased. Then the blood pressure is gonna decrease. Then your patient gonna develop cardiac arrest. This is a so fast process. It can happen within minutes, especially on the pneumothorax. This is our treatment for pneumothorax. First of all, just to rule, release the air and stop the further accumulation. Release the air that accumulated in the pleural space, and then stop the further accumulation of the air into pleural space. And the spontaneous or iatrogenic, not This is rule number 2 in the pneumothorax. Do not ICT every pneumothorax patient. Do not chest tube every pneumothorax patient. Most of the small pneumothorax, it will resolve with just small element of oxygen, and it will resolve conservative. Large pneumothorax, most of them, they are requiring an ICT, intercostal space. We know that مثلث الأمان, the safe triangle on the fifth intercostal space, on the anterior axillary line, or the teres major and your nipple level, and your axilla is the top of it. This is the safest triangle to put an ICT there on the fifth intercostal space. Tension pneumo, I want to stress on 2 points. The new guidelines of ATLS, which is work for both for the tension pneumo due to traumatic or non-traumatic, they changed the position of the intercostal chest tube from the second intercostal space to the fifth intercostal space for the needed decompression for the tension pneumo. There is multiple reason for that. They say the mortality and the harm on the second intercostal space and the depth of the needle. A lot of physicians, they are not aware about the depth of the needle, the size of the needle, and there is multiple crucial organs behind the second intercostal space, not as I mentioned on the safest triangle. For that, if you're gonna decompress your patient that have a tension pneumo, decompress them on the fifth intercostal space anterior axillary line. Then the definitive management is the chest tube in the same place. You can notice in chest X-ray there is an obvious lucency here. There is no lung tissue, there is no interstitial tissue, and there is an obvious tracheal deviation toward the contralateral side. And you can notice the mediastinum, the whole mediastinum shifted toward the contralateral side of the pneumothorax. For that, the IVC or the venous return, it will be minimized. The cardiac output, it will be minimized more and more. The blood pressure, it's gonna go to the floor. خلاص. Then he's gonna have a cardiac arrest. The same way here. Is antithoracic pressure, decreased pulmonary venous return, then hypotension and tachycardia, and then minimizing of cardiac output, then the cardiac arrest. This is a simple pathway for the pneumothorax, for the traumatic and non-traumatic pneumothorax. There's 2 pathways, stable and unstable. Stable, normotensive, normal blood pulse, oxygen saturation more than 90. There is no hemothorax, and his respiratory rate is below 24. Most of them, they will respond to the conservative treatment. Unstable, I mean by it, and if the patient is hypotensive and tachycardic and he's severely dyspneic and he's hypoxic, there is a big suspicion of tension pneumo. For that, decompress them immediately. If in the traumatic, we will not talk about it, and hemothorax, I think Dr. Rawan, she will talk about it on the trauma day. Just one thing, for the size of the ICT, recently we are using the big tail or the small needle, and there is a recent study on the اتوقع انه 2019 I think, they are comparing the ICT intercostal chest tube and regular chest tube, a traditional one, with the needle aspiration or the big tail. They found the bacteria have lesser side effects, lesser downside, lesser complication, and patient he will be more comfortable with the bacteria rather than to ICT him or to chest tube him. And length of stay on the hospital. By evidence, bacteria is a good choice, and needle aspiration is a good by using it in needle aspiration. Sorry. يبدو لي وصلنا للختام. Always I'm giving some reference that I use it or I didn't use it or I recommend it for either medical students or intern or EMS. This is a booklet from Ottawa, just handbook. I think 50 pages. سهل الهضم، ما هو عسير الهضم جدا. You can read it within 2 days, 1 day. Most of the presentation on our area, they have it on this handbook. You can either capture the screen لو عندك Android, iOS. You can scan by your cam. I upload it on my Drive account. Also, this website I highly recommend it for the interns, medical students, and also EMS and nurse. I highly recommend it. There is we call it a flipped classroom. They have an amazing videos that illustrates most of the presentation in our emergency department in a good way and so superficial and simplified way. Also, you can capture the screen, and also you can put your cam on it. It will direct you to my Google Drive account. Also, this one I highly recommend it for the interns especially. شوية طويل، يعني ممكن إنه توقع 600-500 صفحة زي كذا، بس لما بتصفح فيه بتحس إنه نفس الكلام، سهل الهضم، مو عسير أبداً، مرة in simplified way. واحدة دائما من الأشياء اللي دائما بقولها في أي محاضرة في الإمرجنسي or if I will present an emergency topic، دائما بتكلم إنه الإمرجنسي ميديسن community is the best. واللي جوة الكوميونتي هذه يعرف ذا الشيء تماما. الانترنز, the medical students, they have a huge interest toward the emergency medicine residency program. Please consider it as a specialty. It's a new coming specialty, growing fast, so fast. For me, أنا بحس إنهم I'm calling them, all of them, they are my family. Please feel free to contact me regarding anything toward the emergency specialty. If you have any question, you do not hesitate to contact me. ودائما بقول إنه هي معركتنا في الحياة مو مع الجهل، مع المعرفة، ولا يمكن ننتصر مع المعرفة لأنه ما أتينا من العلم إلا قليلا. فدائما كونوا بالحياة معلما ومتعلما، دائما خذ من كل مكان في العلم علما، وكن للجاهلين معلما لينا، لا تكون معلما قاسيا. أبدا لا يدخلك الغرور، راح يفسد اللي تعلمته واللي راح تعلمه. This is my card, this is my contact, my email, my social media account, including the Twitter. You can capture it, you can scan it. أتوقع حان وقت الأسئلة. We are on the time. جميل جدا.
الله يعطيك العافية دكتور عبدو، كانت محاضرة شيقة جدا وكانت مفيدة ومن جد مرة استفدنا منها. حنعرض لك الآن الأسئلة اللي جمعناها كلها، تقريبا هي كلها 9 أسئلة، حنعرضها الآن ونختم بعدها.
Please, I'm waiting for your feedback. يعني ما في أحد منا في الحياة حتى لو قدمت في أي مكان قدمت لنفسك ما راح تستفيد شيء كبير، لكن لما تقدم للناس أو تعطي معلومة للناس you should wait for feedback, you should ask for feedback. I'm waiting for feedback. إحنا ما راح نتقوم في الحياة هذه إلا feedback من الناس. If there is any suggestion, any concern, anything, please report it to us. I'm waiting for the question. Questions?
بس ثواني يا دكتور، حنعمل شير للسكرين بس ثواني كده.
تحت أمرك. دكتور ممكن ترجع للكود حق الكتاب؟ أبشر طال عمرك. تحت أمرك. There's multiple resources، يعني مو بس الكتاب هذا والهاند بوك، بس الكتاب هذا أنا I recommend it للستودنتس. راح تلخص حتى الامرجنسي ميديسن بلوك والكورس في الهاند بوك ده، مرة جميل جدا. I highly recommend it. ونفس الكلام الفيديوز دي for flipped classroom. You capture it. مين اللي سألت؟ تمام. Doctor, can you recommend the book for effusion? Most important information of medical years, all the specialties, not only emergency but secondary medical students. والله أعتذر عن الإجابة، يعني السؤال ده ما أعرف والله. ممكن في ناس مختصين وفي ناس عارفين أحسن مني، يعني ممكن تسأل الميديكال ستودنتس اللي هم في الفورث والفيفث والسينيور ميديكال ستودنتس. You can ask them about this. لكن أكيد إنه زملاتك أو زملائك راح يعرفوا good resource.
دكتور، هذه هي الأسئلة وكل سؤال قدامه السلايد اللي سألوا فيه. يعني
ممكن تسوي زوم بعد إذنك؟ ما عندي شايف زي الناس والله. زوم كذا لا. طيب مو مشكلة مو مشكلة. رانيا, what is the difference between centralized X-ray and non-X-ray? I think she's meaning إنه centralized و non-centralized chest X-ray. If you're gonna work later on the hospital emergency department, you will know that most of the patients you will mislabel them with diagnosis that like aortic dissection or hilar infiltration or widening of the mediastinum or a lot of diagnoses that the patient they are not centralized well. احنا قلنا في الإكس-راي do not comment on the spinous process if it's dissecting the trachea on the midline and you say this is most likely centralized chest X-ray. No, you're going to comment on the bilateral clavicular heads, two heads, midway between them, you will check for the spinous process, the cervical and the cervical area. If it's on the spinous process, dissect the two clavicular heads midway, this is most likely centralized chest X-ray. There's multiple criteria for the proper chest X-ray in terms of adequacy, penetration, inspiration, rotation, even the completeness of the chest X-ray. I cannot say it all of it right now. I have a huge interest toward the radiological emergency. We can arrange for a lecture later if you want. Rania also, I think she's the same. Can we differentiate with the wheezing of asthmatic patient with the saturation of ما عرفت السؤال. I couldn't understand it والله. طيب اللي بعده سارة. In what cases we use ABG for asthma? Good question. Most of the asthmatic patients, they are not requiring they are not indicated for ABG. ABG لما ventilated patient اللي هو على mechanical ventilation intubated، لكن ABG for non-intubated patient ما راح يفرق كثير، يعني CO2 ما راح يفرق معك كثير، blood gas in terms انه ABG ولا FBG. But most of the intubated asthmatic patient, this is a rule number one. واحد من consultant, he said to me one day, do not intubate any patient, please, asthmatic patient, please do not intubate. And this is the last resort. It's a nightmare. راح تجلس في جنبه، لو انت في الشفت راح تجلس 8 ساعات في جنب الفنتليتر. It's so difficult. But this is rule number one for any resident or for any physician: do not intubate asthmatic patient until there's no any solution. Isa Baloui, MBD asthma complicated by upper respiratory tract. Do we need chest X-ray? Most of them we didn't need it. يعني there's no indication, as I mentioned before, unless they are receiving multiple sessions, either 3 sessions or more, and we are having a high pre-test probability in terms of infectious process. This patient most likely have infectious process, or this patient require for admission, even the admission is not mandating chest X-ray. Asthmatic patient, we are misutilizing, we are overshooting them by X-ray, even the pediatric. We are overshooting them by X-ray. As I mentioned before, there is no need until you have high pretest probability for bacterial process or other complication rather than to be asthma exacerbation. لما why inner city resident risk؟ طيب imagine that لو ما أعرف أنا كيف، لو أنت من جدة أو أحد من جدة مثلا، حتى لو من الرياض، accessibility to emergency department، لما asthmatic patient they have difficult to access the emergency department, they will consume a long time to access the emergency. يعني واحد عايش في قرية نائية جدا، ولا مو عايش في قرية نائية، مثلا في أبحر الشمالية والمستشفى قراجة في الحرس الوطني في الهاي واي جدة مكة هاي واي، it's so difficult for him to access the emergency. يعني الزحام حق الطريق، difficult of accessibility, keep it in your mind for any patient, asthmatic patient. وهذا risk factor you should keep it. أتمنى إنه وضحت السؤال. نفس الكلام it will work for خشم العان، حرس الرياض إنه في خشم العان، والجهة الثانية هناك لو كان في جهة جنوب الرياض أو شيء. is difficult في accessibility in emergency department, it's considered for risk factor or asthma patient. طيب ريان، ما شاء الله ريان، racemic AB or IV for what يا ريان؟ for bronchiolitis nothing work. لكن one day one of the consultants he taught me انه a severe form of exacerbation of asthma, do not play with them. اسبقوا بمراحل. hit him early. كل الجنز، كل البيج جنز اللي عندك الميديكيشن use it, utilize it. In terms of EPI, IM EPI, magnesium sulfate, shoot them with the big gun. لأنه الأزمة بيشنت لو سبقك ما راح تفوز عليه، ما راح تلحقه أبدا. عيسى, how could you differentiate between COPD exacerbation versus decompensated heart failure? This is a huge and excellent question, عيسى. Huge debate recently in the future. وراح نبقى أبد الآبدين على الديبيت هذا. How can we differentiate between COPD and decompensated heart failure? الدايلما الكبيرة between medicine and cardio. This is purely COPD. This is purely decompensated heart failure. Just, I'm gonna give you a few tips. Either COPD, they underwent for BFT, and you can stratify them you can classify them on the severity of COPD exacerbation. This is one thing by BFT. Another thing, decompensated heart failure دائما بيكون cardiac status دائما بتكون minimized. ودائما they have low ejection fraction. They have a background. Even لو ما جاء background, this is first presentation, so with the patient he developed decompensated heart failure, you can use a lot of stuff. There's multiple schools, they are using multiple lab tests like PMB. I didn't prefer it personally, لكن I like lung ultrasound. It's a magic. It's a magic for differentiating undifferentiated chance of breath. Put your probe on your patient lung, and you noticed if there is a diffuse B line or there is a B lines, which is indicate that there is pleural fluid or interstitial fluid. This is most likely toward the heart failure process. In combination of your remaining exam. For that, I'm using a lung ultrasound always to differentiate between those type of people. Other thing, PBG. PBG is a wonderful test. If they are returning, they are most likely to have a COPD exacerbation other than to be acute decompensated heart failure or sympathetic acute cardiogenic escape اللي هي sympathetic cardiogenic acute pulmonary edema ولا decompensated heart failure by using a PBG. And look, put your eyes on the CO2. They are returning. This is most likely COPD exacerbation, most likely. I'm not saying it's frank COPD. This is most likely COPD. Lisa. Also Isa. What is the time from onset of BE to RP dysfunction? Okay. I like your question, Isa. Frozen. سلمك الله. Even there is 4 classification for BE. We cannot reach RP dysfunction until we have a big element or a big picture of pulmonary hypertension, or there is a big element of increase in the pulmonary vascular resistance. For that, we are not seeing, we are not appreciate the ECG findings on acute BE patient until they have massive or submassive. Massive, submassive, they have RP dysfunction. But in mild and low risk BE and medium risk BE, they will not show an ECG findings. They will not show as acute or subacute pulmonary hypertension picture until 1.5 weeks. This is from Rosen. For that, we can appreciate the ECG findings. والECG findings ما بتجي إلا في الRP dysfunction ولا الacute or subacute pulmonary hypertension. Right heart strain, complete heart block, right ventricular block, الECG findings will be. طيب. اتمنى انه جاوبت السؤال انك ان شاء الله الكوشن حقتك حلو. What is the difference between pulmonary meniscus and pleural effusion? No. Meniscus, it's a radiological finding of pleural effusion. There's no different, the same. But keep in mind, you will not notice the pleural effusion in chest X-ray until you have a big amount of pleural fluid. Like in chest X-ray, we couldn't appreciate until we reach 200, 250, up to 300 ml. But on ultrasound, we can notice up to 10 ml or 15 ml of fluid. For that, I said I'm ultrasound enthusiastic, but يعني ماني بايس، لكن سماعة القرن ال21 الالتراساوند. طيب قدير، if the patient is dyspneic due to heart failure, can I give loop diuretics? هذا الكويشن اللي عاجبني جدا جدا. انا الهارت فيلير مره توبك كبيره وفيها different stuff، ما نبغى نبحر فيها، نبغى نحل بقيه الاسئله عشان يمكن الوقت ازف خلاص ووقتنا لازم نرحل. لكن الكلاسيفيكيشن للهارت فيلير mild, moderate, severe. Mild, you can use some sort of diuretics like Lasix or something like that. Moderate to severe, you're gonna approach nitro drip, nitroglycerin drip, or infusion, or bolus, small bolus. I mean, if there's any contraindication. Also, BiPAP. BiPAP for decompensated heart failure, severe form of decompensated heart failure, and severe form of COPD exacerbation. It's a magic. تحس إنه أنت ساحر. بيجيك البيشنت severely distressed, he's approaching intubation، خلاص أنت حاطط you are putting the tube, you are putting the crash cart behind him, and you put him in BiPAP. Half an hour, 1 hour, he's deep sleeping. I like BiPAP for severe form of sympathetic cardiogenic acute pulmonary edema ولا pulmonary edema ولا acute form of acute severe form of COPD. But in mild to moderate, you can use diuretics, but keep in mind كل ال evidence بتقول إنه most majority of heart failure patients, they are either euphylemic or hypofylemic. I mean by that إنه ال intravascular status they are depleted. And they are euphylemic or hypofylemic. For you are offer diuresing them. Then you're gonna cause iatrogenic AKI, acute kidney injury, by this. But mild, I like it. Give Lasix. But even treating of bronchiolitis is an art. Treating the heart failure is an art. I can ما اقدر احدد اشياء كثير. يعني الهارت failure is amazing topic for me. احب to talk about heart failure، بس عشان ما نظلم الاسئله البقيه. طيب ديما الشهري in case patient came to emergency department complaining from short breath, oxygen saturation 88 as early intervention, do we need for BiPAP even while patient is fine with the nasal cannula with oxygen saturation? Not that we didn't get the FBG yet. أول حاجة البايباب is not generally indicated for any patient. احنا تكلمنا في أول سلايد في الفاندمنتالز إنه قلنا we are arranging the oxygen source upon our patient demands or our patient needs. فأنت تقول لي نفس الكلام إنه your patient is totally fine nasal cannula, keep him in nasal cannula. That's fine. Do not put a BiPAP for patient. مزعج البايباب، مزعج، بس is a magic. الناس الابروشنج يعني intubation it's a magic. هو نايترو ماجيك في الهارت فيلير، وهو الحاله في COPD exacerbation severe form it's a magic. not for every patient. nasal cannula, face mask, Venturi, non-rebreather, BiPAP later. But ABG will help classify severity of asthma where to admit the patient. Who said that? You cannot rely on one paper. You cannot rely on just a gas status or a gas paper. You can rely on your exam. Nothing work for classifying or risk stratifying your patient more better than your judgment. في كل الميديكال field, your judgment is superior to anything. PBG is gonna work. I like PBG, but I hate to say that we are ordering labs. If the patient show leukocytosis, we're gonna admit them. We're gonna classify severity. If they didn't show a patient, he's gasping. There is no need to order a CBC or any lab investigation. He's gasping. He's in severe form. This is mandating admission. Do not rely on a number. Do not rely on a result. Please. For that, أتمنى إنه أجبت لسؤالك. There is no rule of ABG. آخر مرة سويت ABG قبل 3 سنوات. What's the difference between bronchial asthma exacerbation, COPD exacerbation, ventilation strategy? Oh, I like the question. A lot of stuff, but mainly الباثوفيسيولوجي حق bronchial asthma a little bit different from COPD. COPD, most of them they have a mucus plug. You want some sort of ventilation that keep the alpha recruitment, and you want some sort of pressure or beep on the alveoli to keep it patent. And most of them they have a shrinked alveoli, and most of them they have difficulty to get the air in due to what? Due to mucus plug, due to interstitial fluid, and due to alveolar shrink. But on the asthma, most of them they have a big element of difficulty to exhale and also to inspire, but they have a big element of bronchoconstriction. Alveoli, it will be patent in most of them. In COPD, the alveoli is gonna be shrinked, and there is multiple mucus plug. For that, the BiPAP works wonderfully مع ال COPD patient. Not that much indicated for bronchial asthma patient until they are crushing. أتمنى إن جبت أسئلة زي كذا. في باقي أسئلة؟ بجاوب على أسئلة.
دكتور
قولي طال عمرك.
بس بالنسبة لرانيا اللي هي أرسلت سؤال وقلت سؤالها مو مفهوم.
إيش هو السؤال؟
وضحت السؤال في الشات. اللي في سؤال كان مو مفهوم اللي هي من رانيا وضحت السؤال في الشات. اللي هو you told us that the wheezing not only present in asthma and I mean by my question that can we tell this patient have asthma because of wheezing and shortness of breath.
وين هو؟ رانيا, yeah. You told us
أيوه.
that wheezing not only present in asthma, and I mean by my question that can we tell this patient have asthma because of wheeze and shortness of breath with low sensation? I like the question. Bronchial asthma, most of us, we are not diagnosing bronchial asthma in ED settings. Even this spirometry, it will not work. It will not give you a good picture for the asthma exacerbation or this patient having an asthma. For that, asthma patients, if there is any suspicious of asthma disorder, you should send your patient for pulmonologist or to do for him BFT sometimes. But on the other hand, asthma, majority of the symptoms and signs symptoms are to be family history of asthma. He's wheezing, he's young, he's not having, and I cannot say اللي هو delayed asthma اللي بتطلع في ال 50s ولا هذه، يعني وفي كلام كثير عليها. يجيني majority of bronchial asthma patients they are young 20 18 30 40 they will not develop a cardiac disease. For that البكتشر بتكون واضحة. If the patient have a cardiac disease, most of them they will underwent for BFT or cardiac workup. For that you can differentiate لو كان في باك جراوند للبيشنت عندك. أتمنى إني أجبت السؤال. I think history and clinical finding is major and diagnosis of COPD. Absolutely yes, Amri. Absolutely, you're right. Clinical findings, I like it. But if you work in an ED setting, most of the time يعني إحنا بيصير بينا dilemma how can we differentiate between COPD and heart failure, and this is pure لأنه most of the COPD patient they get heart failure, right side heart failure ولا left side heart failure. For that we couldn't differentiate between them. يعني ما بيكونوا typical picture كذا زي ما يقولوا frank ولا slam dunk. And he need ABG not a FBG in this case. Treat patient not the numbers. No, he need a FBG not ABG in this case. إلا في ventilation setting. I like it. Treat the patient not the number. I like it. عجبتني إياها. طيب. إيش باقي؟ Can we differentiate between cardiogenic and non-cardiogenic pulmonary edema and COVID suspected patient? Okay. Good question. أول حاجة you're gonna notice if the patient have a background of heart disease. This is one issue. Other than this, the patient is slightly elderly, old baba, old mama, they will have a cardiac issue. For that, they're gonna develop the pulmonary edema, cardiogenic or sympathetic cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema, which is mean by pulmonary edema, non-infectious process due to infectious process or ARDS or ALI. On the heart size, you can notice, and you're gonna do for him echo. If there is no any valvular heart disease, obvious valvular heart disease, or valvular heart abnormalities, or by eyeballing ejection fraction, you notice a good contractility. He's not hypokinetic. He's not showing any wall motion abnormality. This is most likely toward the non-cardiogenic pulmonary edema, not the cardiogenic. And you can have both of them on the same time. يا رب جاوبت على سؤالك ووضحت الصورة.
الله يعطيك العافية دكتور عبدو، ومن جد شكرا على تواجدك والمحاضرة اللي أكثر من رائعة، وشكرا على جهودك اللي بتبذلها معانا. فعلا يعني من جد دكتور أنت مثل أعلى. ونشكر لكم حضوركم جميعا، ونتمنى أنكم تكونوا استفدتوا واستمتعتوا في يومنا الرابع. وبكرة حيكون موضوعنا عن البري هوسبيتال كير، حينبسطوا فيه باراميديكس مرة كثير وحنستفيد منه كلنا. وننتظركم غدا في نفس الوقت الساعة 7:15، وننتظر مشاركة آرائكم على الهاشتاج في تويتر. ويعطيكم العافية جميعا، ويعطيك العافية دكتور عبد.
More than welcome. نراكم على خير إن شاء الله. تذكروا دائما هل جزاء الإحسان إلا الإحسان. نراكم على خير بإذن الله. حفظكم الله.